Hi, I'm Dr. Joel Lobo from Ajax, Ontario, Canada. I'd like to present an interesting case of a second-look arthroscopy following a superior capsule reconstruction. The patient is a 55-year-old right-hand dominant homemaker. She complained of bilateral arm pain and her right was more symptomatic than the left side. She tried physiotherapy, non-steroidal anti-inflammatory medications, over-the-counter medications, and narcotic analgesics. Unfortunately, she did not find these to be helpful. She is a healthy non-smoker. On physical examination, we noted a painful arc of abduction with positive impingement findings, abnormal scapular kinematics, and reduction of her active glenohumeral joint range of motion. Her strength was measured at 4 out of 5 for supraspinatus and infraspinatus, and 5 out of 5 on manual muscle testing of the subscapularis. On her initial imaging, her x-ray showed superior migration of the humeral head with some rounding of the greater tuberosity, but her glenohumeral joint did not have any arthritis. These were compatible with Hamada stage 3 changes. Her MRI scan, however, showed a large full-thickness tear with fatty atrophy of both the supraspinatus and infraspinatus, compatible with Coutelier stage 4 changes. We discussed multiple treatment options, and she wanted to proceed with a superior capsule reconstruction. At the time of her arthroscopy, it was confirmed that her rotator cuff was indeed irreparable, and we wanted to proceed with a superior capsule reconstruction at that time. We found a 4 by 4 centimeter tear and a type 2 acromion. We proceeded with a superior capsule reconstruction using an Adams per string internal brace, 3 anchors on the glenoid side, 3 anchors on the medial row of the humerus, and 2 anchors laterally. I placed her into an abduction brace post-operatively and allowed her passive internal and external rotation for the following 10 weeks with progression thereafter. During her post-operative course, we noted a slight increase in her visual analog scale rating at about 3 months, and I thought that this may have been due to the fact that we initiated strengthening at that time. Her pain seemed to decrease over time, and her other shoulder became increasingly symptomatic, so we did shift some focus to that side. However, looking at further SOS data confirming her Western Ontario rotator cuff scores and ASES scores, we noted that her function actually worsened from 6 months to 1 year post-operatively. At this point in time, we obtained an MRI scan of the right side to determine whether or not the ArthroFLEX patch was still intact. Radiographs were also obtained, showing some slight superior migration of the humeral head, but overall a well-maintained subacromial space. Her post-operative MRI scan showed good anchor integration at the greater tuberosity and at the glenoid, and an intact graft from medial to lateral and anterior to posterior. We did notice, however, that there was some superior migration of the humeral head and perhaps some abrasion of the graft on the undersurface of the acromion. At 1 year post-operatively, we also noted that the graft spanned nicely across the glenohumeral joint superiorly, and there was healing indeed of the anterior rotator interval and healing to the infraspinatus tendon. Treatment options at this point discussed included watchful waiting, subacromial steroid injection, and an arthroscopic subacromial decompression with a second-look arthroscopy. She wanted to proceed with the latter option. At the time of arthroscopy, we noted that there was good graft healing on both the glenoid and the humeral side with neovascularization and formation of a neolabrum. During dynamic arthroscopy, we noted that the glenohumeral joint was well sealed off, again with good healing of the glenoid and humeral sides of the graft. This is a view of the arthroscopic portal posteriorly. One thing to note here is that there is vascularization within the portal and bleeding. I found this to be quite interesting, noting that we had seen neovascularization on both the glenoid and the humeral side, but there also seems to be some neovascularization within the graft substance itself. We therefore decided to go ahead and lyse these adhesions, but did notice that there was good synovialization of the fiber tape on the lateral part of the graft. We proceeded with the lysis of adhesions and an arthroscopic subacromial decompression. At the end of the subacromial decompression, we noted that there was good graft stability superiorly, and the graft was nowhere near the undersurface of the new acromion. Prior to the undersurface subacromial smoothing and acromioplasty, we did notice that the graft came close to the undersurface of the acromion. Moving forward and learning from this case, I now counsel my patients differently when they have Hamada stage 3 changes. We talk about superior capsule reconstruction as a treatment option, but perhaps there are other options available to them as well. I did notice that the SOS system was quite useful to track her pain and her function post-operatively, and in most patients this acts as an early warning sign to determine whether or not further treatment is necessary. The graft healing was quite satisfactory to the anterior and posterior rotator intervals, restoring the superior capsular integrity. There was neovascularization of the graft at the greater tuberosity and at the glenoid, and formation of a neolabrum, as well as synovialization of the fiber tape. Moving forward, I would consider adding an internal brace as described by Ravenscroft from the glenoid to the greater tuberosity to prevent any further superior migration of the graft. And also, as described by Mihata in his original work, I would also consider a subacromial decompression as part of the index procedure. Thank you.